Good morning, everybody. So for the next 25 minutes, we're going to have a whistle-stop tour of pediatric tips for the diploma and the MFD. So there's usually one pediatric dentist on every examination team, so you will get questions about pediatric dentistry. So my role here this morning is to try and extract some of those questions that I hear coming up constantly. And all of the information that's here is in your Dropbox account that you have access to. So instead of writing furiously, you will be able to access the information on that. One of the most common questions is this condition here. Can you identify this condition and tell me what the etiology of it is? So what is it? Early childhood caries. And what's the most likely cause of early childhood caries when the pattern of decay is in the upper anterior region, on the labial surface of the upper anteriors? What's the most probable cause of that? Prolonged bottle feeding beyond the age of 1. So what advice would you give to the parents? Stop the bottle. And if they say, well, the child won't go to sleep at night unless they have a bottle, what's your next line of defense? Take some Valium for yourself? No. What you tell them to do is you dilute down the offending material in the bottle until it gets to the stage where it's a non-decay producing material. So in its more severe form, this is the clinical picture that you might encounter. And a question that would frequently be asked is, what's the difference between early childhood caries and rampant caries? So how do you know the difference? Well, the difference is that traditionally the lower incisors are not affected in bottle feeding caries, early childhood caries. And in rampant caries, all of the teeth are affected. So if you look at that clinical picture, you can see in the lower anteriors there that the incisors aren't affected. So the next question that I might ask on that is, well, what would your treatment planning be for that patient? What diagnostic tests would you carry out? You would carry out an examination, you would do special tests, would be radiographs. What sort of radiographs? Bite wing radiographs. Why do you need to take bite wing radiographs in the primary dentition? Because 75% of cavities are undetectable unless you take bite wing radiographs in the primary dentition. And that was a study done by Hennon and his co-workers. So you need to know everything about nursing bottle mouth, early childhood caries, rampant caries, and the differences between them. Rubber dam will nearly always come up in the examination in one form or another. It may come up in the diploma from the point of view of identify the particular items that are necessary to place a rubber dam in a pediatric patient. And the subtle differences are that for a pediatric patient, it's 5 by 5 rather than the usual size is 6 by 6. So it's a smaller frame and it's a smaller type of rubber dam. And the other materials that you need are dental floss. And the purpose of the dental floss is to floss it down into proximally. And what else? Yeah, if you're trying on the rubber dam button and you don't put a piece of floss on it and it pops off the surface of the tooth, there can be a misadventure there. So you routinely tie a bit of floss around the actual button or clamp. And what's the flat plastic instrument for when you're placing a rubber dam? It's for everting the rubber dam. In other words, getting that seal around the margins of the teeth. So let's think about an OSCE question. OSCE question might be, you are given a specifics of a quadrant that is to be, that a rubber dam is to be placed on. So in the OSCE, you will have looked at this question before you actually entered the station. So you'll say to yourself, I've got to put this rubber dam on this mannequin on the lower left-hand side. So the trick is to know beforehand what you're going to do so that you're tuned into that, because it's a 5-minute station. You have 5 minutes to put that rubber dam on. And if you're faffing around at the start, reading the question, trying to figure out is it up or down or left or right, you've already lost a minute and a half. Then the pressure sets in. Then your hands are starting to maybe move a little bit, and that's when the rubber dam splits. And all of a sudden, you're back to square one again. So the thing to do is, first of all, to practice between now and an MFD Part 2 exam, on the basis of that you probably will be asked to put a rubber dam on. And I'm not giving away any information that isn't out there at the moment. If you look at the websites, there's a list of the things that they ask you. I'm not saying that they will consistently be asked, but rubber dam is one of them. So you must be able to put it on with your eyes closed. Don't go into the exam not having put a rubber dam on for the last 5 years, because you will do disastrously at that station. And that's 100 easy points that are gone. Okay? So you must know how to put a rubber dam on. Tip number 3, pulpotomy. Pulpotomy, what's the definition of a pulpotomy? It's removal of the coronal pulp, leaving healthy, vital pulp tissue in the radicular root portion of a primary tooth or of a permanent tooth. And the two key words there are coronal and radicular. You must remove the coronal and you leave the radicular healthy pulp behind. Now the indications for a pulpotomy are carious exposure of primary teeth or as interim pulp therapy for permanent teeth. So those are your two options. But probably the most important things are the contraindications. And the contraindications are if there's an abscess present, if there's nocturnal pain, because that's been shown to be consistent with inflammation that has already gone down into the radicular portion. If there's an intraradicular radial lucency, or if there's advanced root resorption. So intraradicular radial lucency, this is what the actual radiographic appearance of it. And it's intraradicular in between the roots. And on pediatric patients, that's a consistent finding in a tooth that has already infected. What's the significance of an intraradicular radiolucency? The pulp is dead. There's some sort of tissue in that area. And what's the risk with it? If it's asymptomatic, why not leave it there? Sure, it's only a primary tooth. This is what you hear consistently. It's only a primary tooth, let's leave it there. It acts as a space maintainer. Does it act as a space maintainer? If the interproximal surfaces are already decayed, no. The teeth just collapse in on each other. So it's pretty useless as a space maintainer. But there's an even more important reason for not leaving it there. The danger is of causing Turner's hypoplasia. How does that happen? That would be the next question in the Viva. How does that happen? I hear silence. So because I'm going to tell you the answer now, there won't be silence when you actually come to the exam. The reason for that is that the tissue, if you looked at that tissue under a microscope, histologically there's granulation tissue there. What's the pH of granulation tissue? Is it acidic or basic? Acidic. That's how you get Turner's hypoplasia. So let's look at this clinical picture here. Second primary molar, and if you look closely you can see there's an area of hemorrhage there, and there's actually an exposure present. And if you look at it very closely, the exposure extends for that distance there. What are your possible choices of treatment for that tooth? Will a pulp cap work? No, because it's too extensive. It's any more than 0.5 millimeter. There are a number of studies that show that doing a pulp cap will not be successful. Your second choice, and probably the most logical one, is to do a pulpotomy of it. So if you've satisfied yourself that there's no intraradicular radiolucency, there's no nocturnal pain, there's no abscess present, it's a pretty good bet that if you do a pulpotomy, it'll be successful. What's the success rate of pulpotomies on primary teeth using the right criteria? Is it 20%, 40, 50, 60, 70, 80, 90? 90 is the correct answer, over 90%. And again, the studies that we've done show that consistently. So 90% success rate with an actual technique in dentistry is pretty good, isn't it? Providing you use the right criteria when you're doing it. The most important step in a pulpotomy is the one that's highlighted in red. control the hemorrhage. When you go to do a pulpotomy, what you do is you open up with a Fisher burr. In other words, you de-roof the pulpal chamber. You get a massive amount of hemorrhage there. You remove all of the pulpal tissue, and the best way to do that is with a round burr rotating in a counterclockwise direction. The reason for counterclockwise is that it doesn't cut, so therefore it doesn't penetrate through the floor of the tooth, which is the big kind of newbie mistake that people make when they're doing their first 1 or 2 pulpotomies. So if you rotate it counterclockwise and just let it sit there, it does the work for you, but it won't actually cut down through the tooth and perforate the floor of the tooth. But you get to the stage where you've removed all the pulp, and you can do that with a spoon excavator. So you're removing all of the coronal pulp, leaving the radicular pulp intact. What do you do then? You control the hemorrhage. Why is that important? Because that's your most important diagnostic sign. When you do a pulpotomy, what you're interested in is making sure that the inflammation doesn't penetrate down into the root portion. Because if it goes down into the radicular portion, is a pulpotomy going to work? No. So you must make sure that the hemorrhage stops spontaneously before you apply the medicament. Now you might say, well, what I'll do is I'll put the medicament on, and sure, if it stops, it stops. If you put ferric sulfate on there, will the bleeding stop? Yes, because ferric sulfate is actually used as an obtundant. But you're doing away with your most important diagnostic sign, and your success rate with the pulpotomies will fall correspondingly. Okay, why do you restore the tooth with a stainless steel crown? Why not just put an alloy in there, or a resin, anything like that at all? So there's enough tooth there to embrace it. Does a tooth become stronger or weaker after it's been pulpotomized? Weaker. And because the particular anatomy of a primary tooth, if it's going to fracture, where does it fracture? Cement to enamel junction. And where is that located? Below the gingival margin. Is it easy to put a stainless steel crown on a tooth that has fractured at the cement to enamel junction? No, it's really difficult. So you want to prevent that, so you put the stainless steel crown on at the time. Okay. What's the best medicament for using as a pulpotomy medicament? Formocresol was the gold standard at one stage, and then it fell out of favor because of the fact that people think that it's carcinogenic. But the actual evidence for that is extremely limited, and in many parts of the Middle East, formocresol is still used routinely there. But on this side of the world, the materials that are used now are ferric sulfate or MTA. No difference in success rates between the two. But the reason why ferric sulfate is the one of choice is because it's an awful lot less expensive than MTA. What happens if there's an abscess there? Can you root treat that tooth? Will a pulpotomy work? No. Can you do a pulpectomy? You can. Is it easy? No. What are the success rates? The success rates are probably less than 50%, and this is why. If you looked at the left image there, that's an acrylic representation of the internal architecture of the canals of a primary tooth. Now, if you can tell me that you can successfully root fill that tooth, you're way better than I could ever hope to be. What I actually think you do when you do a root filling on a primary tooth is you're doing a pulpotomy at a lower level. You're removing as much of the pulp as you can. You're praying that because you removed most of it, that the actual medicament there is going to actually work. And this is one that was successful, but realistically a 50% success rate is very poor. And what's much more predictable? To extract the tooth and then to put in a space maintainer. Okay. Space maintainers. Unilateral space maintenance. If there's one side and you want to maintain the space, you use a band and loop. Okay. So band and loop, unilateral space maintenance. So when the technique for doing a band and loop, you adapt a band. You take an alginate impression, you pour it up, and then you bend the wire. And the important thing for the design of it is, if I said to you when you come into the exam, well, I'd use a band and loop. And I'd say, well, tell me about band and loop. Pretend that I'm a student and you're telling me how to make a band and loop. Tell me about the design of it. And you'd say, well, it's a wire and it touches the tooth in front. But that's not really enough, is it? What is the magic thing about the design of this? How wide should it be across the alveolus? It should be wide enough to accommodate the premolar tooth that's coming up underneath. When a premolar starts to erupt, the tissue swells. If you go straight back with the wire, when the premolar starts to erupt, the wire will become engulfed with gingival tissue. And then you've got to remove it. And it's quite difficult explaining to a parent why you have to remove this 2 months after you put it in and charge them for it on the basis that your design in the first instance was so poor that it just didn't work. So it's better to know beforehand what the pitfalls are. So the actual wire should cross the middle to upper third where it's soldered against the band. It should touch the tooth in front, and it should come down below the crest of the ridge. And you would cement it on with glass ionomer cement. Frequent question: what size wire do you use? I'd use a big wire. That's not quite what the examiner is looking for. They would not want to, and they'll hammer you on it. They'll say, well, what's a big wire? Would you go for 0.4 millimeters? And you say yes, because an examiner would never lead me astray, would they? So 0.9 millimeters. All of the space maintainer appliances, all of the thumb appliances that you use, it's 0.9 millimeters. Just think of that. Or 0.036 inches if you want to convert it into feet and yards. So unilateral space maintenance band and loop. An alternative to that is you can use a thing called a crown and loop. And this is what you're hoping to result with. You see the way, because the design is wide enough, the premolar erupts up into the middle. Okay, so it's important to get the design right. Crown and loop is similar to a band and loop. The only difference is that the wire is soldered onto the stainless steel crown. And the advantage of that over a band and loop is that it's service free. It's cemented in place. With the band and loop, sometimes they can become dislodged and you've got to re-cement them. Bilateral space maintenance. Only 3 things that you need to remember: lingual arch in the mandible, a transpalatal arch, or a Nance appliance in the maxilla. Again, made of 0.9 millimeters. So lingual arch, how it works is that it rests on the cingula of the lower incisors and it prevents mesial movement of the first permanent molars. Nance appliance, the retention comes from the bands, and there's an acrylic button in the palate, and that prevents the mesial movement. The way a transpalatal arch works is, even though it goes straight across, for maxillary teeth to move forward, they must rotate around their palatal root. And that is an anti-rotational device, so that's how that actually works. So those are the 3 appliances: unilateral space maintenance band and loop, bilateral Nance appliance, lingual arch, transpalatal arch. Primary incisor trauma always is a question that will come up in either the paper or the OSCE or the Viva. The concussion, intrusion, lateral luxation, extrusion, and avulsion. If you take the first letter of each of those, it gives you the word cilia. So if you can remember cilia and the examiner asks you, tell me about primary incisor trauma, you're away with it then. You can then say, well, there's concussion and that, so you're really moving properly. What do parents want to know? Will they lose the primary tooth, and will the permanent tooth be harmed? So will they lose the primary tooth? It's more likely if the apex of the primary tooth is deflected apically. So with concussion, maybe, intrusion, maybe, lateral luxation, yes, they will lose it, and avulsion, obviously they will, and extrusive luxation. But it's not the primary tooth that we're interested in, it's the permanent tooth. And the direction of movement of the primary incisor determines the likelihood that the permanent incisor will be affected. So the 2 key injuries that result in much higher incidence of damage to the permanent tooth are intrusion and avulsion. Those are the two. And there's about 70% for each of those. Have you ever seen where if a child gets a bang on a primary tooth and it turns dark and it's there and there's no infection, there's nothing on the radiograph either. So what do you do about that? Well, there was a very good study done by Holan, and he found that 50% of them will actually become lighter again. The reason why it turns dark is this extravasation of red blood cells into the tissue, and then they're incorporated again, so it actually turns lighter. And 50% of them will stay dark but remain asymptomatic, and the other 50% will need treatment. I don't know how you get 150%, but anyway. Just quickly, a bonus tip for you, crossbite appliances. Posterior crossbite like that. Tell me 3 appliances that you can use for a posterior crossbite. So there's loads of different ways of treating it. You can use cross elastics, but from the point of view of actual appliance therapy, the quad helix appliance, the W arch, the mini expander, or the Hyrax. Okay, so what you do is you overcorrect it with the quad helix, and you overcorrect at the stage where the lingual cusps on the upper teeth are opposing the buccal cusps on the lower, because you always get a bit of relapse. Those are the 3 appliances there. There isn't a Hyrax there, but a Hyrax is basically a variation of a mini expander. What condition is that commonly seen in 6-year-old, 7-year-old children? Commonly seen on a radiograph. Okay, that's ectopic eruption, where the first permanent molar erupts under the second primary molar, and it's due to a short dental base from anterior to posterior. What's the treatment for that? Very good study done by Pulver. Pulver showed that 60% of them will self-correct without any treatment, and the other 33% will actually need treatment. What about anterior crossbite? Tell me the appliances that you can use for that. You can use a segmental appliance like this. In other words, 3 little brackets, twist a flex wire, move the tooth forward. And there's variations on that theme. You can use this was one that was done with a Hawley appliance. So if you said, well, I would use a Hawley appliance, and I'd say, well, tell me about a Hawley appliance. And what are the components of it? The components are Adams clasps, there's an acrylic base plate, there may be a posterior bite platform to open up the bite, and then the active component of it would be Z springs or whatever variation that you want on that. Okay, this is the very last one in 2 minutes and 35 seconds. This is the boring part, okay? So this is cephalometrics made easy in a minute. You could be given a tracing like this, and you will be asked to identify and put on the points on it, the most commonly used points for cephalometric analysis. So there's nasion, and we'll come back to the definition in a minute. There's cella, A point, B point, the maxillary plane, gonian, gnathian, mandibular plane, SNA, SNB, and ANB. So what would be skeletal 1? What would the ANB angle be? Normal. What's normal? About 2. What's abnormal? What would be a class 3? 0 or a minus value. And what would be a class 2? 4, 4 plus. Okay? So that gives you the skeletal pattern. So if you're given a cephalometric and you're asked to trace it and then measure it, those are the points that you need. Now these are the definitions of those points, and this is on your Dropbox account. Okay. And you need to know these definitions. So to emphasize that, so you get your tracing, then you put in your points, and you do your measurements, and then you need your definitions. Now, if I've shown this twice, it means that this is important, isn't it? Yes. Okay. So you got point A, point B. You must know these off by heart. Because again, if you know these and you get a question on cephalometrics, it means that you're going to get close to 100%. So if you get 100 in the rubber dam and you get 100 in the cephalometrics, you're not doing too bad at this stage. And then you've got your CPR station. So you're flying along. The new dean is looking at me as if I'm giving too much away here. Okay, so you go through your points like that, and you end up, and hopefully what you will achieve is an excellent result. Thank you very much.